So, hello everyone. My name is Lulu. So today I'm going to talk about point of care ultrasound in the diagnosis of pulmonary embolism. First, I'm going to talk a little bit about the background. So we all know that venous thromboembolism, including PE and DVT, is the leading cause of cardiovascular deaths worldwide. And we should suspect PE in patients presenting with shortness of breath, chest pain, syncope, shock, hypotension, or cardiac arrest without an obvious alternative cause of an ischemic cardiac event. So the use of transthoracic echocardiography in patients with PE is pretty common. There's a recent meta-analysis in 2017 show that right heart strain was the most common sign used in the diagnosis of PE. But as we can see here, the echo alone has a relatively low sensitivity and pretty good specificity in diagnosis of PE. So it can be used as a routine test at bedside for patients with a suspicious of PE, especially those unable to get other confirmatory studies. But if we use lung, heart, and extremity ultrasound at the same time, it can increase the sensitivity in diagnosis of PE significantly. And there's studies show that multi-organ ultrasonography is more sensitive than single-organ ultrasonography and increases the accuracy of clinical pre-test probability estimation in patients with suspect PE. So this study in 2014 showed that if we combine the three different ultrasound, we can increase the sensitivity to 90%. So today I'm going to talk. Next I'm going to talk about lung, heart, vein ultrasound findings of PE respectively. So first, for the lung and heart ultrasound, we can use first phase array probe, and also for the lung, we can also use the curvilinear probe. And so, and now I'm going to talk about the ultrasound finding of PE in lung and heart ultrasound. So first, for lung, we can see a hypoechogenic pleural base lesion on ultrasound, which represent lung infarct. It's usually like a triangular or a wedge shape or rounded homogeneous hypoechogenic lesion between the pleural line. And it has pretty good sensitivity and specificity according to several studies. And here we can see the picture here. We can see the subpleural hypoechogenic lesion here. In a correct clinical setting, it can represent lung infarct. There's a study which included 352 patients. Patient in suspect PE, and the patient were investigated prospectively by ultrasound according to these criteria. So the PE is considered confirmed if two or more typical triangular or rounded pleural-based lesions were found. It's probable PE if one typical lesion was found with pleural effusion, and it could be possible PE if a small, less than 5 mm subpleural lesion or a single pleural effusion alone were found. So the study found by using this criteria, the sensitivity was 74% with a specificity of 95% in diagnosing PE. When we only use the first criteria, this two or more typical triangular or rounded pleural-based lesion, the sensitivity is only 43, but the specificity is pretty high. It reached like 99%. And next is the D sign. It's a sign of significant right heart strain. So basically, it means on the peristernal short axis view, the left ventricle become a D-shaped structure. It's a result of right ventricular strain causing a shift of the septum towards the left side of the heart. So we can see this under parasternal short axis view of the heart. The next sign I'm going to talk about is McConnell's sign. It basically means ignition of the right ventricular lateral wall with a hyperdynamic appearance of the right ventricular apical wall. So this can be seen under the apical four-chamber view. So this is the McConnell sign. We can see the hyperdynamic apex here. And there are several mechanisms have been proposed that may explain this finding. First is that in acute PE, the tethering of the right ventricular apex to the contracting and often hyperdynamic left ventricle may account for the preserved wall motion at the apex. Second is the right ventricle may be assuming a more spherical shape to equalize regional wall stress when subject to an abrupt increase in afterload due to PE. And third, there may be also localized ischemia of the right ventricular free wall as a result of increased wall stress, and all this lead to the ignition of the RV lateral wall with hyperdynamic apex. Next, I'm going to talk about is the 60/60 sign. So the 60/60 sign in echo refers to the coexistence of a right ventricular outflow tract acceleration time less than 60 milliseconds with the pulmonary arterial systolic pressure of less than 60. So in the presence of right ventricular failure, it's consistent with an acute elevation in afterload, commonly due to an acute PE. So first, I'm going to talk about how to measure the PA systolic pressure. It equals to a tricuspid gradient plus right atrium pressure. So for right atrium pressure, we can estimate it from the CVP. So, and for CVP estimation, we can use IVC. So this is a normal appearing IVC. So the estimated right atrium pressure is 8. The picture on the right showing like collapsing IVC, collapse more than 50%. The CVP is lower. Here is 3, and this one here show a dilated plethoric IVC. So the estimated RA pressure is about 15. And after we have the RA pressure, then we can start measuring the tricuspid gradient. So in order to measure the tricuspid gradient, we must first identify the tricuspid regurgitation. If there's no regurgitation, then we cannot measure the gradient. So first we need to obtain an apical four-chamber view of the heart, and then we can use the color Doppler to see if there's regurgitation jet here around the tricuspid valve, and here we can see the blue jet here, and then we can the continuous wave Doppler spike should be placed in the path of the jet, and then we can get this picture on the right. So then we can measure the peak velocity of the regurgitation. After we got the Tmax, then we can calculate the tricuspid gradient by using this formula. So if it's less, then we can, after we got the RA's pressure and the tricuspid gradient, we just combine these two numbers, and if it's less than 60, is suggesting acute, like acute core pulmonary. But do you know, however, the normal subjects will have a RV systolic pressure less than 60. This sign should only be applied to patients with signs of RV strain on the ultrasound and a significant pulmonary hypertension, typically with RV systolic pressure or PA systolic pressure above 40. So chronic elevation in right ventricular afterload allows serious compensation change, and which including chamber dilation and increased wall thickness, and this allowed the preservation of RV stroke initially at a markedly elevated pressure. So if it's a chronic RV, elevation of the RV afterload, the PA systolic pressure should be above 60, but if it's less than 60, it's more suggestive and acute, like acute core pulmonary. So next, after we got the PA systolic pressure, then we can measure the pulmonary acceleration time. So first we need to obtain a parasternal short axis view, and we need to just slide, we can get the mitral valve, get a view at the level of mitral valve first, and then we slide or fan the probe to get the pulmonic, to see the pulmonic valve, and then we can place the pulse wave spike through the pulmonic valve at the RV site, and then we can get this picture here. So the pulmonary acceleration time is the time between the onset of the systolic pulmonary ejection and the peak flow velocity. If it's less than 105, it's a marker of raised pulmonary artery pressure in general. If you have a acceleration time less than 60, with the pulmonary arterial systolic pressure also of less than 60, and also signs of RV strain like D sign or RV dilation on ultrasound, that's suggesting PE. Next, I'm going to talk about TAPSE. So TAPSE means tricuspid annular plane systolic excursion. There's recent literature show that it actually is more sensitive for diagnosis of PE than other signs. Here's another study showing TAPSE has a good, pretty good sensitivity and specificity in diagnosing PE in patients with elevated heart rate and hypotension. So how to measure TAPSE? So first we need to obtain an apical 4-chamber ultrasound view, and then we need to put the MO, and then we put an MO cursor along the lateral part of the tricuspid valve ring, and then we can get this MO picture here. So the TAPSE is the distance between the minimal excursion to maximum excursion. It's a distance measurement. So if TAPSE is less than 17, it's suggesting RV dysfunction, and also can be used as a signs of signs in patient who has PE. And another signs in PE is RV dilation. So the normal RV to LV ratio in diastole is 0.6 to 1 on apical view. If the RV is larger than LV, then it's abnormal and suggesting RV like elevated afterload and RV strain. And on the parasternal long axis view, and the RV should be roughly the same size as the aortic outflow tract and left atrium, with a 1:1:1 ratio. And if the RV is larger than the other two, then this indicates right heart strain. So next, I'm going to talk about DVT ultrasound. So first, for DVT ultrasound, we need to have the patient lying spine, and then externally rotate the patient's leg and bend the knee into this frog-like position. And this position can enlarge the vein and bring it closer to the field of vision. And so for DVT ultrasound, we are using linear probe because it's like a shallow structure. Now let's review the anatomy. The venous anatomy of the lower extremity is pretty simple. So going from proximal to distal, we have the most important veins in the leg we need to know for DVT is the common femoral vein, and coming down the great saphenous vein. At this level, the common femoral vein gives rise to the deep femoral vein, and then it becomes femoral vein. And following the femoral vein down at the knee level, it becomes popliteal vein, and then at the calf level, it gives rise to three deep vein, which are anterior tibial vein, peroneal vein, and posterior tibial vein. So for the DVT ultrasound, this exam involves compressing the identifying vein and confluences to identify whether there's a clot or not. So first, when we are doing the compression, we need to make sure the vein and artery are in the center of the view, and then we just compress at a perpendicular angle with enough pressure to bring the walls of the vein together and slightly compress the walls of the artery. So there are several different protocol to do a DVT ultrasound. There are 2-point lower extremity DVT ultrasound, 3-point, and a whole leg complete lower extremity DVT ultrasound. So for 2-point lower extremity ultrasound, we are only doing compression ultrasound at the common femoral vein level and popliteal vein. And for the 3-point, we do compression ultrasound at common femoral vein, and popliteal vein. And for the whole leg complete lower extremity DVT ultrasound, it involves scanning the leg using compression, color Doppler, and pulse wave Doppler from the common femoral vein all the way to the ankle while evaluating the calf veins. So actually, studies have found that 3-point compression ultrasound protocol to be most feasible while maintaining similar sensitivity and specificity when compared to a whole leg scan. This shows like there's a prospective diagnostic test assessment of 3-point ultrasound conducted in patients with suspected DVT in the lower limb. It shows the accuracy of 3-point ultrasound carried out by the emergency physician was assessed by comparison of the Doppler ultrasound carried out by the radiology department as reference standard. Studies show like the 3-point DVT has very good sensitivity and specificity in diagnosing DVT when compared to the whole leg scan. So today I'm going to talk about the 3-point ultrasound, lower extremity ultrasound for DVT. So first, so when the step 1, so we first put the probe along the inguinal ligament midway between the pubic symphysis and the anterior superior iliac spine, and then we just slide a probe or fan probe to find the common femoral vein and artery. And here we can see the vein and the artery lateral to the common femoral vein. And after we find common femoral vein, we can apply firm pressure with the ultrasound probe until the artery compresses slightly. In a normal scan, the vein should compress entirely. Then we slide the probe 1 to 2 centimeters down to find the great saphenous vein branch of the common femoral vein. And then we compress the common femoral vein at the junction with the great saphenous vein. After that, we can slide the probe 1 to 2 centimeter down. The patients like to find where the common femoral vein branch into the deep femoral vein and superficial femoral vein. And after we find the femoral vein, then we do the compression again, just distal to the bifurcation to see whether there's clot or not. And then we move the probe down into the posterior crease of the knee and scan 2 centimeter above and below and to find and try to find the popliteal vein. After we find the popliteal vein, then we can do the compression again to check if there's a clot. After that, we can just move the probe distally and try to find the trifurcation of the popliteal vein, and then compress the popliteal vein until we find the trifurcation. Once we find the trifurcation, that's the signal. That signals the end of the examination. So this is the 3-point protocol. This is the steps of 3-point DVT ultrasound. So so the ultrasound finding of DVT, we can see the clot directly, and we see a non-compressible vein that's also suggesting DVT, and also we can use the color Doppler to help us identify clot. So here we can see the hyperechogenic things inside the vein, which suggesting clot. And when we apply pressure to the skin, we can see this vein does not compressed completely. And also we can see some hyperechogenic things inside the vein, so that's also suggesting blood clot. Here we see the same thing. And next we can use a color Doppler and see here there's reduced flow in the color Doppler, and here there's no flow at all, so which suggesting there's a clot here. So the take-home point of my presentation is a triple multi-organ ultrasound, including lung, cardiac, and vascular, has relatively high sensitivity and specificity in the diagnosis of PE, and it's recommended for patients that cannot receive a CTPA. And the ultrasound finding suggesting PE in the lung, we can see subpleural hypoechogenic lesion, suggesting representing lung infarct, and for the echo, we can see signs of right heart strain, like these signs for 60/60. I think all the signs I talk about, it's basically indicating right heart strain, and which is commonly seen in PE. And also we can do a lower extremity ultrasound to find DVT.